Section 7.4 Pressures on the Variant Classification Industry. 7.4.1 Budget Cuts and Limitations on Variant Classification Science. Madhuri, Hegde. Patient care is the most important casualty of limited budgets and resources, because reports are not going to be high quality in these situations. This directly compromises the quality of care the patient receives and the quality of the report itself. Stanley. When health insurance payers do not reimburse or reimburse poorly, labs are forced to process more cases with fewer resources, increasing the probability for error. Automation cannot replace highly qualified variant interpretation staff who do a thorough evaluation of patient reports. Also, publication paywalls can impact classification by preventing access to the evidence, in which case either the evidence is not used in classification, or the classification is based on the abstract alone, with no critical review of the evidence. Eggington. The process of variant classification is not regulated in any meaningful way by CLIA or CAP, and the FDA-approved NGS tests often have major portions of the test that are not actually regulated in a way that would safeguard against misclassified variants. Clinicians and health insurance payers have little to no insight into the variant classification quality of laboratories beyond what they hear in sales pitches. Decreasing the quality of variant classifications provides massive savings to laboratories with no consequence. So many labs cut corners. Patients, however, unknowingly pay with their lives due to misdiagnosis. 7.4.2 The pressure to upgrade variants of uncertain significance in the name of compassion. Madhuri, Hegde. If we consider a recessive germline case in which one pathogenic variant has been identified, the other variant is a VUS, and the phenotype matches the gene, indicating you are probably in the correct gene, then abstaining from delivering a therapeutic regimen is not right. Keep the classification of the variant as VUS, i.e. do not upgrade the variant to pathogenic just to deliver therapy, but do the compassionate action and deliver treatment. In cases such as this, we need a mechanism to track whether the patient responded to treatment, and to give that information to the variant classification community. I suggest a clinical response category for ClinVar. Iain, Kerr. If the data do not support a certain classification, then that is what we should communicate to the patient. Stanley. I think compassion plays into variant classification in the sense that we are driven by the patients and a desire to help them find an answer. It's what keeps us up late at night reviewing publications in search of the cause of the patient's clinical symptoms. Section 7.4.3 The Pressure to Increase Diagnostic Yield. Stanley. The expectation of a higher diagnostic yield should actually add pressure to select the right patients for the test and not to overclassify variants as pathogenic for the sake of an appearance of a high diagnostic yield. High diagnostic yields are the result of a combination of selecting the correct patients for genetic testing and having a genetic test that can accurately detect the broadest spectrum of variant types, e.g. single nucleotide variants, deletions and insertions, short tandem repeats, and copy number variants. Madhuri, Hegde. It is nothing short of dangerous to tie health insurance reimbursement to positive test results, as has been piloted by some payers. Policies such as these are not a good idea and will negatively impact the practice of laboratory medicine. One consequence will be an increase in false positive rates.